Everyone, my name is Jackson, and I am going to be presenting my case study to you today. So let me just pull up the case study here. All right. So my case study is on acute pancreatitis mainly. I'll go into um, different conditions that my patient had and whatnot, but let's just start with the overview to give a basic understanding of what this is going to be all about. So a little bit of patient overview of the patient I chose. So the patient story, RW, it was his initials, is a 30-year-old male who was admitted to the ED with acute pancreatitis. He had an upper endoscopic ultrasound performed to look at the pancreas. He then had a stent placed in the pancreatic duct to help drain excess fluid. During his stay at the hospital, he developed an acute kidney injury, also known as an AKI, which is what I will be referring to it as for a lot of this presentation. So, continuing, hold on just a second. For the patient's medical history that is pertinent to his condition in the hospital. So he has struggled with obesity, so he currently weighs 6 feet, or he currently is 6 feet tall and weighs 117 kilograms. So on the BMI scale, that would qualify as obese. He has a history of low back pain, asthma, Posset syndrome in the lumbar region, hypertension. He's had acute pancreatitis before. He's a chronic alcohol user. He smokes half a pack of cigarettes a day for the last 4 years, and he doesn't really exercise at all. So, claiming he exercises 0 times a week. So when we did an assessment, his chief complaint was abdominal pain and nausea, followed by vomiting, a temperature of 38.1 degrees Celsius, and a radial pulse of 93 beats per minute, and a blood pressure of 164 or 96, so the hypertension. He was irritable, sitting at a pain score of 8 out of 10 on the numeric pain scale, so scales 0 to 10. And the pain was primarily in the upper abdomen below the sternum, and the patient described it as constant and dull. The abdomen was rigid, slightly distended, and very tender to the touch. The skin was pallor, bowel sounds present in all 4 quadrants. He had rapid, shallow breathing, 2+ pitting edema in both legs, ankles, and feet, with a urine output less than 400 milliliters in the last 24 hours. And a bladder scan revealed that there was no urine being retained in the bladder. So we're already looking at potentially fluid retention, not just a bladder issue here, since there was no urine in the bladder. So moving on from the overview, that's RW, we're moving to the pathophysiology. So we'll talk about the pancreas first in general. The pancreas is a long flat gland that sits in the upper abdomen, right behind the stomach. Its main purpose is to produce hormones, for example, insulin and glucagon, enzymes, so amylase and lipase, that help in digestion. So it's a very important organ in aspect of digestion. Acute pancreatitis, so pathophysiology specifically of acute pancreatitis. Pancreatitis is a broad term that simply means inflamed pancreas. There are many different types and causes of pancreatitis, and many of them have similarities in their pathophysiology. Since the patient was diagnosed with acute pancreatitis, the pathophysiology specifically of acute pancreatitis will be discussed. So we're not going to talk about chronic pancreatitis, even though a lot of the causes and risk factors and all that will be the same. Acute pancreatitis refers to inflammation of the pancreas that appears suddenly and usually lasts several days. So some of the causes of it can be chronic alcohol abuse. This causes RWs, pancreatitis. So alcohol increases the production of digestive enzymes in the pancreas, leading to autodigestion of itself, which in turn causes the pancreas to inflame. Or gallbladder disease, which is the most common, is a blockage created by gallstones, can cause a reflux of bile acids back into the pancreatic ducts where they shouldn't be, resulting in pancreatic ischemia. So that reduced blood flow there. So that bile should not be going into the pancreatic ducts. It's coming from the liver or the gallbladder, right? It should be going into the intestines. So signs and symptoms of acute pancreatitis is constant and severe abdominal pain. It's going to be the most common symptom there. Pain that radiates to the back and or feels worse after eating. Fever, rapid pulse, nausea, vomiting, tenderness when touching the abdomen, typically followed by guarding. So you can see this little graphic here of this guy holding his stomach and guarding it. So these are all symptoms that RW did present with in the hospital setting. So some risk factors: excessive alcohol consumption, cigarette smoking, obesity, and family history of pancreatitis. Notice anything about these? Well, 3 out of the 4, so excluding family history of pancreatitis, RW fell under these risk factors. So he excessively consumed alcohol, smoked a half pack of cigarettes a day, and classified as obese. But he did not have a history of pancreatitis or family history of it. Complications that can come of it, the main one is the pseudocytes and abscesses. So pancreatic pseudocyst is an accumulation of fluid, pancreatic enzymes, tissue debris, and inflammatory exudates surrounded by a wall, and that's the pancreas. This gets infected, it results in pancreatic abscess and extensive necrosis of the pancreas. The abscess may rupture or proliferate into nearby organs. So you can see that a little bit right here. Right? You can imagine if something that was infected like that ruptured into the nearby organs, right? Our abdominal cavity is technically sterile, right? So that would not be good. So that perforation would be very dangerous. So other complications, some cardiovascular and pulmonary complications would be that pleural effusion, atelectasis, so that collapsion, right? The collapse of the alveoli, pneumonia, and acute respiratory distress syndrome. So he didn't experience any of these in the hospital, but it's still something that's very serious and that can come of this acute pancreatitis. So that was the pathophysiology of acute pancreatitis. So let's talk about it real quick because he did develop that acute kidney injury. This is the pathophysiology of that. So an AKI is a sudden episode of a kidney failure or damage that develops within a few hours or days. This causes the buildup of waste products in the blood and decreased ability for the kidneys to balance fluid in the body. Okay, so some signs and symptoms of this. RW presented with these as well. So these are the major signs and symptoms. So oliguria, right, or oliguria, edema in the lower extremities. That would be a buildup of fluid, right? Fatigue, nausea. So these are all some common signs and symptoms of the AKI. So causes, 3 main causes: decreased blood flow, so i.e. hypotension, direct damage to the kidney, so the use of contrast dye, and blockage of the urinary tract, kidney stones. What cause RWs, AKI? So we're looking at acute pancreatitis. How could that lead to an AKI in the hospital? Well, the diagnosis of acute pancreatitis heavily contributed to the patient's sudden loss of kidney function. So hypovolemia was the culprit here. The digestive enzyme in the pancreas that are being overproduced cause an increase in vascular permeability and leakage of the protein-rich fluid into the interstitial compartment, leading to hypovolemia, which consequently results in acute kidney injury. So restricted blood flow, right, is going to be, or less blood kind of flowing to the kidneys is going to cause that acute kidney injury in this case, because a lot of that fluid is being held near the pancreas, and that creates permeability. It's like kind of like leaking out near the pancreas. Okay, so that's pathophysiology. Let's move on to laboratory data. So let's look at RW's abnormal labs that we found. So his red blood cell count and his hemoglobin were both really low. So because acute pancreatitis causes hypofluemia, it's no surprise that RW's red blood cell count and hemoglobin levels are low, right? So hypofluemia, less blood means less red blood cells, less hemoglobin. Makes sense. And then we also saw that his BUN, so these are basic lab tests that we'd be taking in the hospital. His BUN and creatinine were both really high. So this could be due to, or these are expected findings in an AKI due to the kidney's inability to filter blood properly, right? So creatinine and BUN are really crucial tests in diagnosing that AKI, right? So it's that buildup of those waste products in the blood. Those are what BUN and creatinine are. So other important tests, so these are ones that you wouldn't necessarily do routinely, but it's in suspicion of pancreatitis, whatnot. You might want to take a serum amylase and lipase tests and look at the levels, and they're often elevated due to the overproduction of the pancreatic enzymes. So while both values would be elevated in acute pancreatitis, the preferred test is serum lipase, level. Okay, so that's because there's a lot of other conditions and reasons why the serum amylase level could be elevated. So serum lipase level is like kind of the surefire way to diagnose. So RW's blood tests, because obviously they would have given this to him or taken this test for him, revealed that elevated lipase level of 304 units per liter. Normal range is 7 to 60, and an elevated amylase level of 526 units per liter. Normal range is 30 to 110. So that's awfully high. And helpful in diagnosing this acute pancreatitis. Okay, so moving from the laboratory data onto medication. Medications for acute pancreatitis don't normally need too many medications to treat. Rather, it's important to treat the underlying cause of the inflammation and any symptoms and complications that may develop. I have a tickle in my throat. However, RW was on a few medications that are helpful in treating pancreatitis. So I listed 3 here that were that stood out from other patients maybe in the hospital, right? Because a lot of the patients are on similar medications. So one of them is Protonix. So Protonix, pantoprazole, is a proton pump inhibitor that helps decrease the hydrochloric acid secretion in the stomach. So hydrochloric acid stimulates pancreatic activity, right? So this is a big one for helping kind of neutralizing that acid, right? So calming down the pancreas. It's not necessarily acting on the pancreas, but it's kind of secondary to the pancreas. Then we also have Tums, so calcium carbonate. It's an antacid that was prescribed to be used as needed to neutralize gastric hydrochloric acid secretion, so to hopefully relieve nausea and vomiting so the patient can potentially start eating again. So this patient, RW, is actually on NPO restrictions because he's throwing up everything. His stomach is so upset, it's so acidic, right? So anything to help get his stomach calm and whatnot so he can start eating again is really important. So that's why calcium carbonate it's important medication is prescribed to him. While calcium carbonate is a common medication that someone may have in the household, in the hospital, it can be used for a very specific reason, and that being this. And the last one is morphine. So it's a narcotic used to treat moderate to severe pain. Common symptom of acute pancreatitis is severe pain that can't be evenly even be fully relieved through drug therapy. So having medication that is strong enough to relieve as much pain as possible is important for patient recovery. Morphine is a high-risk medication for addiction and dependence, so use it only when necessary. So our W is experiencing pain. He had that 8 out of 10 pain when it was noted. And on, oh, I thought I was going to sneeze. But nothing really ever took his pain away completely. So that's why the use of morphine can really help, because even though it's like a heavy, heavy painkiller, if we can take about away as much pain as possible, that is the most ideal situation for him. So morphine is an important, and you'll see this in a lot of acute pancreatitis patients. So moving from medication to nursing care. So we have a few different things here. Obviously, nursing care is super broad, but RW was diagnosed with acute pancreatitis upon admission to the hospital. During his stay, he developed an AKI. Nursing care will revolve around these two diagnoses as well, prevention of future complications. So obviously, patients in the hospital have all sorts of different nursing care and orders and whatnot. Lots of them overlap, but we're going to talk about ones that maybe are a little more specific to RW's condition here. So the first one is deficient fluid volume. So risk for deficient fluid volume related to excessive bodily fluid losses, so vomiting and gastric sectioning. So RW is MPO, so you would not be receiving any sort of hydration via the mouth. It's important to keep the patient hooked up to the IV and continue to administer fluids. RW's blood pressure and other vital signs should be taken at least every 4 hours to help spot any changes in blood volume. Eyes and nose and daily weights taken to help monitor for fluid retention and balance. The goal for RW is to maintain adequate hydration as evidenced by good skin turgor, appropriate urinary output, and strong and stable vital signs. Then for pain, so a lot of patients have pain in the hospital, but we're going to talk about acute pain related to the autodigestion and inflammation of the pancreas as evidenced by a report of constant pain at a level of 8 out of 10. Pain assessment done frequently, so every time a nurse is in the room, they should be asking his pain anytime they give medications, but at least every 2 hours. Noting verbal reports of pain, location, intensity, and factors that aggravate and relieve the pain. And drug therapy, it will help the patient stay relaxed and get a better night's sleep and recovery, right? So we have that morphine prescribed, and we have other lesser medications that will help with pain, but typically that morphine is what is being given now. Involves nutrition, so related to vomiting and loss of digestive enzymes, as evidenced by inadequate food intake. So assess RW's abdomen, look at the bowel sound, distension, nausea. So this is something that I was doing when caring for this patient. Look at the stool, urine, color, consistency in the mouth. The goal for the patient is to demonstrate weight gain towards normal weight and experience no signs of malnutrition. So this is kind of, you look at it like you have the AKI, he's maybe retaining fluid, so he's gaining weight through there, but losing weight because he's not consuming enough food. So it's important to look at how much food he's being given, look at his urinary output, but also how much stool he is producing. See, is he gaining weight for the right reasons? Labs. So monitor his lab values. So while 1 in 5 hospitalized patients developing acute kidney injury is still a very serious condition, he is losing filtering abilities, so dangerous amounts of waste may build up in the blood. Therefore, monitoring lab values is important because too much of certain electrolyte like potassium can lead to very serious cardiac dysrhythmias. So auscultating those heart sounds and looking at those labs and making sure that they're in the right range and whatnot. And then patient education, a big one here. So the cessation of smoking, right? We talked about those risk factors. These are all modifiable risk factors right here. Provide patient with resources to help quit, whether this is recovery group, whether this is places that he can get a prescription or buy nicotine gum, right? Patches, whatever it is. Limit that alcohol intake. Same thing. If he needs to find a support group for this, right? There's AA and whatnot. So talk to him about this. Like, how can we achieve this goal? Not just telling him this needs to happen. And increase exercise an average of 30 minutes a day for 5 days a week. So this can start off as something like just going on 30 minutes of walks a day, right? So try to plan with him, getting, we can prevent those further issues from coming up. So, in conclusion, the RW was admitted to the hospital with acute pancreatitis, but during his stay developed acute kidney injury. Between the risk factors and lifestyle choices, which overlap, RW's diagnosis made a lot of sense. This is why patient education is an important factor for caring for patients. While it wasn't like typically expected, his condition, it wasn't as much a surprise when you're looking at the risk factors and whatnot. So in order to prevent further complications, RW must make some lifestyle choices or changes, or else these acute conditions will turn into chronic conditions like chronic kidney disease or chronic pancreatitis, right? So further changes are needed to be made. And then, so for the pathophysiology and whatnot and different information, I did use some references. So here are my references. And then if we were in person, I would ask you guys if you had any questions. But other than that, I hope you enjoyed my presentation, walking through RW's journey through the hospital with me. And I hope you learned something and can apply it to your future in nursing. Stop share. And yeah, have a good day.